Hi, and welcome to the second installment in a series on cardiac arrest treatment and CPR. The first video was the why it's important that we focus on this, and this is more of a practical lecture on how we can improve what we do and what we should be doing during resuscitations. Just as a little aside, this is one of our code stat reports from a crew before um, instituting this, and if you see the periods of compressions, especially initially, are vastly variable in terms of how big the breaks are, and rates are all over the place each minute. Don't worry too much about this if you're not familiar with these reports. That can be separate. This is the same crew after paying attention to some of this training, and you can see their compression ratios are much improved, and their rates, especially using a metronome, are right on. So early improvement and room for even more improvement with more practice. Um, So, choreographed chaos, that sounds a little bit like what we're doing often. If anybody's been to a cardiac arrest before, been part of the resuscitation, you know it can seem like chaos. And what our goal is to choreograph that, similar to what these guys have done in auto racing in the pit crew, and therefore the quote unquote pit crew model of CPR, also referred to as high performance CPR. Why do we call it that? Well, if you've ever changed a tire, you know this scene. And regular CPR is to that type of changing tires what high performance cardiac resuscitation is to what these guys do. That 2.3 seconds, four tires changed plus the fuel up. If only we could all do that, right? So our goal is to choreograph our cardiac arrest care so that we know what we're doing, everybody has a role, and things flow the way they're supposed to, and that allows us to focus on the things that are important and put our efforts towards the things that really matter and really make a difference and get rid of some of the extraneous efforts. This is taken from others who have put this similar sort of model uh, into practice. And what we're going to use is this simple model of a triangle to show where the initial provider should be, what their role should be, and how this can expand from there. So, Pit Crew CPR, you hear it referred to as many things. I like the high performance CPR just to really point out that what you're doing is really turning something into the highest possible performance you can do. Anyhow, bunch of different names. There's a lot of different versions, but really what this is just a way to focus on three main goals. Those goals are early defibrillation and early chest compressions. In the last lecture, you saw that it makes a difference how early we defibrillate and how early we start compressions. Number two, minimize pauses in chest compressions. And we tend to pause a lot more than we think, and unless you're really focusing on this, it's hard to cut those pauses down. If you focus on it, it's incredible how few pauses you really need during a resuscitation. And third, make every compression the best possible quality that it can be. There's some secondary goals. We want to control our ventilations, and we want to do the medications and other procedures that need to happen, but really those take a backseat to the first three. And just again to focus on those. If any of this gets too confusing, you get in a resuscitation, you forget where any of the finer details. Really, the things you need to focus on are early compressions, early defibrillation, minimizing pauses, and making the compressions that you do good quality. Some of you have probably work in systems where you respond to a code and you feel similar to this guy here. Others may be in roles where you respond and you feel like the room is similar to this. There are way too many combinations of responders to cover every possible scenario with this type of lecture. So what we're presenting is more of a framework here. This can expand and contract based on how many people show up. And the goal is to provide something that's flexible. And, you know, if it gets too confusing, when you're confused, go back to those goals. Focus on uninterrupted good compressions. Communicate with each other what you're doing and what you see, and your outcome will be essentially the same. You'll reach the same end if you're working towards those goals. Again, key points, it varies depending on how many people show up and the training level of who shows up. But again, just focus on keeping the compressions going and making them matter. Just a little aside, if you have enough people, if you're in one of these roles over here, don't forget to assign somebody to the family or bystanders when it's feasible. You're treating the patient, but you're also treating the family and those that are around. And if somebody can guide them through this, uh, what is often a traumatic process for them, that can be hugely helpful. So, a couple, just to break this down a little bit, compressions. Key points with the compressions. Whenever possible, a metronome should be used for rate. We've tried it with and without here in Gallatin County, and we've seen huge differences instituting a metronome. The results were very impressive how quickly things changed. We tend to compress way faster than we think when we're not using a metronome, and that can be detrimental. And this is just a key part of making your compressions good quality. When you're the person doing the compressions, whenever there's a break for pulse check or for defibrillation, just lift your hands an inch or two off the chest. Then you're in place, you're ready to go as soon as the code leader tells you to restart compressions. You don't have to get in position again. It helps minimize the breaks. It doesn't shave off a lot of time, but again, it shaves off some. It keeps you focused on what you're doing, and it's part of that high performance. And focus on depth and appropriate recoil. This is something that can be hard to do, especially in the longer resuscitations as people get tired. Don't feel bad about having somebody critique you, and do the same for others. In the heat of the moment in a code, it's hard to keep track of everything, and if we can learn to take coaching from each other constructively and give it constructively, that can go a long ways. Timer. As soon as you have enough people, assigning somebody to be a timer can be very helpful. I've had some field providers even tell me that they've used a bystander to be a timer, just instructed them to let them know every 2 minutes. They should keep to a 2 minute cycle, or the timer should keep everyone on to a 2 minute cycle. It's helpful announcing 1 minute and 30 seconds and 1 minute 45 seconds. One thing that can be done as people get more comfortable with this sort of approach to cardiac resuscitation is at 1 minute and 45 seconds, one person can put a finger on a pulse. That way, when the 2 minute mark comes along and the pulse check comes along, they already know where the pulse is and don't need to fumble around trying to find where it was. If you already have your finger on the pulse during the last 15 seconds of compressions, you know where the pulse is, and as soon as the compressor stops their compressions, you know if that pulse is still there and there's return of circulation, or if there's no pulse and you need to either consider defibrillation or restart compressions. Another thing you can do as you get more advanced and more comfortable with this is charge a manual defibrillator at 1 minute and 45. Doesn't mean you need to shock, but then when you see a shockable rhythm, it means you can shock right away without having to wait for the machine to charge. If it's not a shockable rhythm, you can always dump the charge. Defibrillation, key points for BLS providers. There should be an urgency to get the defibrillator in place. Remember, that was one of the key goals, is early defibrillation and early compressions. Anytime a shock is given, compression should resume immediately after the shock. And again, that's a place where hovering the hands over the chest can be helpful. You're safe from getting any shock as long as you're not touching the patient, even if you're just a couple inches above the patient. And that allows you to resume your compressions right away. If you're using an AED, you have to follow the prompts on the AED. For example, you can't do that pre-charge that I was talking about. It may allow you to do a couple compressions while it is charging. However, that's machine variable, and I would instruct you to just follow the instructions that your AED is giving you. Some people have asked about whether there's even a need to check pulses with an AED, because if it tells you to shock, you know it's VFib or VTAC. I would instruct you that you still should check pulses at all times, because there are times when artifact from whatever cause, loose lead or a loose pad or motion of the patient, can simulate VFib or VTAC, and you don't want to be shocking a patient who's got a pulse just because of artifact. At the ALS level, again, once you're comfortable with this and you feel comfortable doing it, a manual defibrillator can be charged at 1:45 into the cycle. The code leader needs to verify whether there's a pulse present or not and look at the rhythm and give an order to shock or no shock. Everybody needs to be on board with this so that there aren't any shocks being given just because the machine was charged. And you should be familiar enough with your machine that you can dump the charge if you're not giving it. And again, compression should resume immediately after the shock. Airway, a couple key points. Airway and ventilation now take secondary priority to the compressions and the defibrillations, unless this is an airway or a respiratory arrest case. If this is a choking victim that has gone through respiratory arrest and then into cardiac arrest, a avalanche victim that has been buried in the snow and you know respiratory arrest was early on, drowning victim, any of those, they need the airway and the ventilations first or simultaneous with the initial compressions. Anyone else, the compressions come first, and then you can focus on the airway. Consider using a non-invasive airway or King airway if it's available so that you don't stop compressions. If you're intubating, you should try and do it without stopping compressions. And there should be strict attention to the rate of ventilation. And again, this is an area where we should all be comfortable giving and receiving constructive criticism or constructive feedback to each other, because it's very easy to ventilate too fast, even if you've done this a whole lot. Remember that use of end-tidal CO2 is mandatory once an airway is placed as soon as it's available. Even for a King airway, once a provider who is able to do end-tidal CO2 continuously is on scene, that should be placed on a King or an endotracheal tube. So here is the scenario we're going to use to build our framework. We've got a cardiac arrest victim in the middle, and then our providers are going to fill in this initial triangle first with positions 1, 2, and 3, and then they're going to start to fill around the outside like this, depending on how many show up. We're going to start with positions 1 and 2. This person here is going to be position 1. This is the person who does the initial patient assessment, determines that there's no pulse, and their immediate job is to begin compressions. 2 minutes of compressions. They have no other job for the first 2 minutes once they've started that, but doing good compressions continuously for 2 minutes. The rest of the crew can focus on everything else. The one exception to this would be a single provider. When there's only one provider on scene, they do have to do the compressions. They also have to set up the AED as soon as it is available, and consider what they're going to do for airway and ventilations after the first minute or so, and first check for a shockable rhythm. Assuming there's more than one person on scene, however, person 1 is going to do that initial assessment and begin compressions. Person 2 is going to be the one to bring and operate the AED. Their first job, to the exclusion of all others, is getting the defibrillator, whether it's an AED or a manual defibrillator, in place, hooked up, and turned on. They then are going to, as things progress, once the defibrillator is on and ready and set, then they can consider doing ventilations. Each time you hit a 2-minute mark, person 1 and person 2 are going to switch. Person 1 who was doing compressions is now going to run the monitor and the airway. Person 2 who was doing monitor and airway, or AED and airway, is now going to be doing compressions. The benefit of this is that they don't have to move around. They can just lean in from one side and start doing compressions, and then lean out at the end of their shift, and the other person can lean in. It avoids having to have people moving around, switching from one place to the other, and it shortens the transition between compressors. So again, position 1, your priority, first person on scene, is to begin compressions. Your focus is on quality and allowing no interruptions, and for the first 2 minutes, you really have no other job than doing that. Person 2, your priority is the defibrillator. Attach the AED or the monitor and get it ready. Get out a metronome if you have one, and once all that is set, then you can think about airway and ventilations. These two people are going to swap roles, but not positions, each 2 minutes. And by not positions, I mean you don't swap from the left side to the right side of the patient. You just lean in and out from one side or the other, and that way you can quickly switch compressors. Now there's some, you see number 4 here, turns on AED after 200 compressions. That was put in here by the folks who put these diagrams together, and I don't feel that there's a strict rule about that. A lot of people question, when should we shock? Should we do 2 minutes of CPR first and then shock after that, or should we shock right away? Really, the reality is there's no hard data on when you should be shocking. My feeling is if there was no bystander CPR, that person had an arrest and they've just been lying on the ground with no circulation whatsoever for the 4 or 5 minutes before rescuers arrive and begin compressions, or longer. It's probably best if you give 2 minutes of CPR before you shock. That allows the heart to get a little bit of blood flow and probably helps the heart be a little more receptive to the shock. If there was good bystanders CPR being done, shock as soon as you get the defibrillator set up, because we know that early defibrillation makes a difference. Same for if you witness the code. If the patient goes out on you in the back of the ambulance and you witness the arrest, as soon as you have the ability to defibrillate, do it if it's a shockable rhythm. Third person on scene. This person now can focus on the airway. You've got one person focusing on compressions, you've got person 2 focusing on defibrillation. Person 3 can then deal with the airway. Their role is to open the airway, get it clear, do a king if available and if they're trained to. If that person 3 is going to be intubating, again, don't stop compressions unless you really need to. And they can set up the end tidal CO2, again, if available and trained to. If they're not using a king, or if you're sticking with bag valve mask for a while, ideally you should do a 2-hand seal. An easy way to do that is person 3 to reach down in 2 hands around the jaw and the mask, and use whichever person, say person 2 who's not doing compressions, to squeeze the bag during their off cycle. Opens and clears the airway, sets up bag valve mask. We're not using impedance threshold devices, these ITDs, you can ignore that. Ideally provide a 2-hand mask seal if using a mask, and then if available inserts and secures the king and the end tidal CO2. BIAD just means blind insertion airway device, essentially the king airway. An airway that you're inserting without seeing where it's going. Blind insertion airway device. Number 4 on scene. Once you have the luxury of a 4th person, now you've got somebody who can kind of run the code and be the team leader. They can assist. They can assist with handing person 3 the king and getting it set up while person 3 is using the bag valve mask. They can start doing some of the other team leader duties. They can organize personnel and assign roles. For example, they can tell when the next compressor needs to come in. They can call the ER and give a report or talk to medical control. They can talk on the radio and give updates. They can be the timer or the recorder. They can also assist by coming around down to the patient's legs and checking femoral pulses during compressions and seeing that pulses are good, showing that good compressions are happening. So once further people start showing up, some of us work in areas where we have the luxury of having more than enough people to fill these roles, and the question is, how do we fill in others from there? Again, person 1 focusing on compressions, person 2 focusing on defibrillation initially, then alternating in on compressions. Person 3, airway. And 4, filling in some of the team leader duties. Say you work somewhere where the first providers are BLS and then advanced provider shows up. They have 2 here. So probably from a system with a double ALS unit that will arrive on scene. One good place for the advanced provider to work from is down here, somewhere at the hip or the thigh. After checking the airway, coming around to the thigh or leg allows that provider to put in an IO, give medications, IV fluids from an IO. They have a good view of the whole code in front of them and can help orchestrate things from there. And by putting the monitor either up here facing down or down, if they bring it in and put it down here facing them, they can view the monitor, run the meds, see the whole code, check femoral pulses, all from one place without having to move around. Some other reminders. Again, you should have somebody timing 2-minute cycles whenever possible to keep you on track. If you're comfortable with it and your team is comfortable with it, consider charging a manual defibrillator at 1:45 into the cycle. And your code leader should find and keep a pulse at that point so that they know right where it is. Whoever's doing the compressions, hover your hands in place during rhythm checks and shocks, an inch or a couple inches over the chest, and make sure you're swapping compressors at least every 2 minutes, if not sooner, to keep from getting fatigued. On that note, you can swap different people into these position 1s and position 2s. They just come in and take the same role of filling in compressions, bagging, or whatever else they may be doing in the off cycle. Again, there's too many combinations of responders to cover all the possibilities. What if 3 BLS and 1 ALS show up, or 5 BLS show up and no ALS show up? This is a framework to use. When you're confused about things, you don't have to remember every little detail. Just focus on uninterrupted, good compressions. These are tools to allow you to do that and communicate what you're doing and practice. I challenge you to work within your agency to practice this as much as possible, ideally monthly. The yearly or every other year practice that we tend to do is not enough for these, and learning this in the heat of the moment is not the way to do it. This is something that needs to be practiced to be done really well and really at that high performance level. Here's a video that you may have seen in the other talk, and this is an example of a crew from Redmond doing their practice drill. So ALS has just arrived. You hear them putting down a metronome. The gentleman in white is filling that position 1. The gentleman on the right is position 3, the airway. The woman in the foreground is essentially the team leader, or position 4. And when they do switch compressors in a couple of minutes, you'll see the other person come in from the patient's left side. One of their advanced providers is using an IV in the arm rather than going right to an IO, which is fine if you feel comfortable with that and feel that's more effective for you. So she just said 15 seconds. You see somebody checks the femoral pulse and they're going to charge the defibrillator. Shockable rhythm. They shock and begin compressions again. See, they're going to intubate without stopping compressions. Notice that the procedures, the intubation and the IV, take a back seat to the compressions and the defibrillation. The gentleman starting the IV stopped what he was doing and stepped back from that role when they came to the chance to defibrillate, and only performed the IV after that. We've seen that there's a team leader. They're using a metronome, and they've got a dedicated person timing. They pre-charged the defibrillator and intubated through compressions. We've got a person at the femoral pulse checking the CPR quality. And now this gentleman in the black vest in the foreground is going to come in from the other side to swap places for compressions. Double checking the rate of the ventilations. You see, when everything's rolling the way it should, it almost looks boring. They got a bunch of people standing around, but that's because they know what needs to be done and they're getting it done. So there was a very well orchestrated pulse check, shock, and compressor change, all within about 5 seconds. And they've got the next compressor coming in from the patient's right, lined up to take the next swap. So again, when you're doing this, three main goals to remember: ensure early defibrillation in chest compressions, minimize pauses in chest compressions, and make every compression the best possible quality that you can. Hopefully what I've presented here are some tools that will help you with that, and help you fulfilling those goals, but those are the ones to fall back on. And really the key to this is practice. Practice with those that you're going to work with, and practice routinely and regularly on this. Thank you very much.